We have a case here where a 57-year-old woman comes to the OPD with the right shoulder pain for the past 2 months. She is unable to raise her arm or reach for objects. She is a right-handed person, but she has recently been using her left hand more because of problems on her right hand. She lives with her child who has recently met an accident and is now immobilized. Before pain, she used to carry him and transfer him to the wheelchair, but now she is unable to do so. The patient's other medical conditions include type 2 diabetes mellitus, Graves' disease, hypertension, and hypercholesterolemia. On examination, there is marked decrease in passive and active abduction, flexion, rotation at the right shoulder. Palpation of the shoulder and acromioclavicular joint do not produce pain. The remainder of the physical examination is unremarkable and the X-ray is normal. Which of the following is the most likely cause of this patient's current symptoms? Option A, adhesive capsulitis. Option B, calcific tendinopathy. Option C, osteoarthritis. Option D, rotator cuff tear. Or option E, rotator cuff tendinitis. Okay, since the patient has been having pain since the past 2 months and the X-ray is normal, we can probably rule out dislocations and fracture. And among the given options, what could be the cause of this patient's symptoms? Let's look at the case first. Pain is chronic and she is unable to move her arm and reach for objects, right? And the range of motion is decreased. Both active and passive range of motion is decreased. That means active range of motion means moving your arms by yourself, and passive range of motion means having the same movement with the aid of some other person. The other person is helping you in achieving those movements. The patient has been having pain in both of those movements. Now, let's go through the options from the down. Let's look at the last two options first. A rotator cuff tear and rotator cuff tendinitis. To discuss about this, we have to first understand what rotator cuff actually is. But even before that, we have to understand the normal anatomy of the shoulder joint. Shoulder joint is one of the most mobile joints in our body, and it is formed by three bones: humerus, clavicle, and the scapula. If you look at the shoulder joint, the head of the humerus fits into the glenoid cavity of the scapula, but the glenoid cavity of the scapula is very smaller in comparison to the size of the head of humerus, so it does not perfectly fit. And for this reason, to support this shoulder joint, there are a bunch of muscles around the head of the humerus, and there are a bunch of ligaments to keep this shoulder joint in position. And one of the group of muscles that helps to hold the shoulder joint in its position is the rotator cuff muscles, which forms a rotation or circle around the head of the humerus. And these muscles are popularly remembered by the mnemonics SIDS. These muscles are supraspinatus, infraspinatus, subscapularis, and the teres minor. They are the muscles in and around the scapula or the shoulder joint. A rotator cuff tears often follow an injury, something like fallen, outstretched hand, and it typically causes weakness with active shoulder abduction and rotation. Right? Whereas rotator cuff tendinitis is an overuse disorder which is characterized by painful abduction and external rotation. And among the rotator cuff muscles, the most commonly involved muscles here is supraspinatus. Patients with these conditions, like rotator cuff tear or rotator cuff tendinitis, may resist manipulation of the arm because of pain, but passive range of motion is normal in this condition. The passive range of motion is normal. If you are helping them in achieving those movements, then that range of motion is normal. But in our patient, both active and passive range of motion is affected. Now let's go to the third option, which is osteoarthritis. Osteoarthritis, it's not actually an inflammatory condition, and it's a pathology which most commonly involves the knee joint. But the osteoarthritis of the glenohumeral joint is relatively uncommon and rare. Osteoarthritis of the glenohumeral joint can decrease both active and passive range of motion as seen in our case. But most patients have a history of significant past shoulder trauma. But our patient does not give such an history, and this condition is very rare. So let's look at something that is more common. Now the second option, which is calcific tendinopathy. The calcific tendinopathy of shoulder is caused by hydroxyapatite deposit in the rotator cuff tendons. In the tendons of the rotator cuff muscles, hydroxyapatite can get deposited, and that causes calcific tendinopathy. It is characterized by pain during abduction, which may be very severe. Active range of motion may be limited because of pain, but passive range of motion remains normal, and calcifications of the tendons are visible on X-ray. In our patient, the X-ray looks normal. Calcification is also not seen. So we can rule out this. Now, our patient has a chronic shoulder pain with decreased both passive and active range of motion, which is consistent with adhesive capsulitis, which is sometimes also called frozen shoulder. Adhesive capsulitis or frozen shoulder is characterized by loss of normal distensibility of the glenohumeral joint due to chronic inflammation, fibrosis, and contracture. It is most common in middle-aged and older individuals, and the risk is increased in patients with diabetes, thyroid disorders, and chronic immobility. It is also common in patients with rotator cuff tendinopathy or fracture of the proximal humerus. But our patient does not have any kind of fracture, and the clinical vignette does not suggest rotator cuff tendinopathy because the range of motion is affected in both active and passive range of motion. Whereas in rotator cuff tendinopathy, the range of motion is usually not effective. Patients with adhesive capsulitis typically report gradual onset shoulder stiffness that limits their ability to flex, abduct, or rotate the humerus. The diagnosis is confirmed by demonstrating a reduction in both active and passive range of motion in multiple planes. X-ray, as in this patient, are usually normal, and imaging is used to primarily rule out other causes of pain. So, in this case, the cause of this patient is most likely adhesive capsulitis or frozen shoulder.